That I just gave was in a session on the treatment best practice models for irregular corneas. And there are so many aspects one should cover when speaking about treating irregular corneas. I try to focus on two. One that is clinically established and a promising new way to treat irregular corneas in the future. The first one is a question that has been debated in the past 5 or 6 years. When you perform corneal cross-linking for keratoconus in an irregular cornea, how do you improve vision best using the excimer laser? Should you combine the procedures or should you rather take a sequential approach? And I strongly believe that the answer to this question is more and more obvious, has become more and more obvious in the recent 2 years. The sequential approach makes most sense for the following 3 simple reasons. Whatever we do in medicine follows the normal distribution curve, the famous Gaussian curve that we all learned during our medical studies, which means most of the patients that you treat will react the way you expect them to react. But there will always be extremes on both ends, and you have to take care of these extremes too. In terms of conventional cross-linking, epi-off, we know that the technique is very safe, but still, in 3 to 7% of patients, you will see failure of cross-linking, even in the standard Dresden protocol. On the other end, in roughly 1 patient in 200, so 0.5%, you will have extreme flattening of 8, 9, 10 or 11 diopters. Now imagine what happens if you combine your cross-linking procedure with wavefront-guided PRK in these cases. Well, in the case of extreme flattening, you will, on top of this, remove 50 microns of epithelium, of stroma. You will end up in a massive hypermetropic shift. That might be very annoying, but not a catastrophe medically yet. But in the 3 to 7% of failure to cross-linking, you will have an additional removal of stroma that can bring you into deep trouble. So on a biomechanically already compromised cornea that does not respond to cross-linking, you remove additional tissue. This is the reason why I, whenever I can, prefer the sequential approach. And I have put all additional reasons to do a sequential approach aside, like delayed epithelial healing, increased haze. The only instance where I perform a combined approach is when the patient has no time to wait. Young patient, contact lens intolerant, that says, "Doctor, I cannot live with my visual acuity as is right now."